Okay. So our last presentation of the afternoon, we're going to talk about a little bit more about some of the health plans, particularly Medicare Advantage, disadvantages, and the disadvantages. So if we're ready to go, we'll just move on with that. Thank you again.
Okay, the potential disadvantages of Medicare Advantage. Where they can cause difficulties, what complications can working with insurance companies cause, what are the potential harms and headaches for physician group practice, and what are the potential risks to the community and to the end user, either the member or to you, when these occur. Some of these we dealt with this morning. Dealing with government programs. I mean, dealing with CMS is a headache. Dealing with CMS and fee-for-service Medicare is bad enough. When you get with Medicare Advantage, it's a closer interaction, so your headaches are going to increase. Now, that's one of the advantages of being with a third party, is that they block and tackle a lot of the problems for you. They can't block and tackle all of them. You're going to be faced with some of them. Even if that includes audit. Every 3 years or so, in my plan, we were audited by Medicare. It's just one of the routine stuff. They go out into doctors' offices and review charts. So that's just more people in your office. Well, I know that you love to have people in your office auditing. Setting up benefit plans. I mean, sometimes you don't get what you want. And sometimes it's almost more confusing. Grievance and appeals. It's helpful sometimes to be in that process so you can intervene and be an advocate for your patient, but that's your time. You have to decide how much time do you have outside of what you're already doing to further block and tackle for your patient. The enrollment and satisfaction programs, to a great extent that's an advantage for you because that makes your patients more satisfied. At the same time, that can add work to you and your staff to do things that supposedly make your patients more satisfied. Trying to deal with black holes in care sometimes doesn't fill those black holes. It's more work and then it doesn't work. And finally, the ratings, this cost of quality. There are only 18 5-star plans in the country. The issue is, and everybody's trying to get 5 stars because at 5 stars, number one, you get paid the most. You get paid 5% more than Medicare. Than what you usually get as a health plan for Medicare, and you can market year-round, whereas normally you can just market in November and December. Well, that's a huge competitive advantage. Well, but there's only 18 out of 600 plans that are 5 stars. It's expensive for a health plan to try to get that last half a star. As I was leaving the health plan I was in, they were trying to decide whether it was worth it. Because we're going to have to spend this much more money. Are we going to make up the difference by what we get paid from Medicare, or is it just going to be a bunch of hassle? And that's a good question. What is the cost of quality? Cash flow, again, that can be a disadvantage if you don't have a good paying arrangement with Medicare. With CPC Plus, is the care management fee, it's not paid, is it quarterly? Yeah. Quarterly? Well, you know, when you do stuff on a monthly basis, daily basis, and you only get paid quarterly, that can be a hassle. The shared savings that we got on CPC Classic were paid yearly. So you did some things with the hope that eventually you'd do that. Now you get this, they sort of pay you this merit-based payment up front, though. Is it $4 PMPM or something like that? And then you might get it if you are efficient with your practice and meet the quality benchmarks, but you don't know if you do or not. Well, so it's a hassle. It can result in decreased patient satisfaction. It's like this health plan that was back home that their patients got a letter saying, you know, your health plan quality sucks, you need to go find someone else. Well, that reflects badly on you. So that's that dreaded letter from CMS. And then if you're capitated, what happens if you spend that whole thing in the first quarter? Then you're working for free the rest of the year. So you have to really be somewhat confident in your ability to manage care to be able to do this well. the data is usually better when you're working with that third party. The problem is, okay, you have all this data, what do you do with it? And one of my pet peeves, and again, I'm the enemy, so I'm with the health plan, but I really got frustrated with physicians coming to me and saying, no, I know that you're giving us a lot of data, but I need actionable data. Almost all data is actionable if you look at it correctly. It's like, and I gave everybody the same data, and one physician came to me and says, you know, I noticed that I have one of the highest lab costs of any doctor in my clinic. I said, I don't know why that is. And so I sat down with him. I says, well, how do you order lab? He said, well, I have the patient come in for their physical, and I have all their lab drawn before I see them, so that when I see them, they'll have it all. So you're ordering things that you don't even know you need before you even see the patient. And it's just kind of like a light bulb went on. Oh, I might not need all that lab. I said, there you go. I said, it's convenient for the patient, but you're paying for the convenience, or someone's paying for the convenience. So then he changed the way his work process was, and he was one of the lowest cost in lab because he ordered lab that was necessary. We're all for ordering all the care that helps, but only what helps. So you can look at there was another woman, great physician. She was so wonderful. And her cost of ER was the highest in the state. And she was flummoxed. She just was appalled because every doctor wants to be the best. And so she said, all this week I'm going to ask my patients if they know that they can reach me after hours. Because she looked at what these people were going to the ER for, and they were for stuff that she could have taken care of in her office. So that week, she said, every patient that came in, did you know that you can reach me after hours if you have a problem? 100% of the people didn't know that. And I know that's shocking because in healthcare, we just take it for granted. Listen, a lot of people out there don't know how medicine works. There are people you're in your offices that probably don't even know what a primary care physician is. So don't take those things for granted. Have a very simply stated policy statement for all your patients so that they know what the process is. If they have a problem after hours, how they can reach you and all that kind of stuff. But again, use the data that you have. There's a potential decrease in the number of patients if they're dissatisfied. And then financially, the Medicare Advantage plan is the most risky because you're at risk, especially the more risk you have. The more benefit that you have, the greater risk you'll have. So, do you want to take it? No guts, no glory. Potential risk, I've not seen a situation where a Medicare Advantage plan actually caused a decrease in medical quality. But you might do a lot of work and get no improvement. And I've seen a lot of that. Even in CPC, there were large segments of CPC Classic that did not see an improvement in overall health. That's why when they published a statement in the journals, they said, we can't tell that it's doing any good. If the plan isn't effectively managed, people can forego needed health care because the financial cost is too great. If my copayment on needed drugs is 30% and that drug is $10,000 a month, I'm not going to get that drug filled. So that's a problem. Managed care does generally moderate the healthcare cost on patients, but it might not be enough to incent recommended care. So that's a disadvantage. You want them to get all the care that they need. And how do you do that? That's a principle in insurance called value-based insurance design. I want to create a benefit plan that will incent people, or at least not disincent them, to get needed care. There are some plans that are making zero copay diabetic drugs because you can no longer say, well, the drugs are just too expensive. They're free. In Oklahoma, what we did is we took all the statins and we made them zero copay. Well, that's a lot of, there are very few diabetics in Oklahoma that aren't on, you saw heart disease, that aren't on statins. So they can't say that they're too expensive. They're free. Beta blockers are free. So that's That's that value-based insurance design. I want to incent proper behavior. That was the principle behind, we want no cost share for recommended screening tests. So for a screening colonoscopy, no cost share. It's free, except for Medicare. Did you know that? If you have a screening colonoscopy in Medicare, and they find a polyp, it's not a screening. So there's cost share. See, we changed that in ours. If it was a screening going in, it was a screening going out. And that's that plan design. So we were able to do that. We told Medicare we were going to do that. They were fine with it. Anybody recognize this? CPC. And I wanted to touch base with a little bit of the things that we learned in Oklahoma that I think that helped us to where we were able to achieve. And this is my caveat. I'm sorry that some of my jokes are inappropriate, and by sorry I mean you're welcome. Okay, I'm a big fan of Einstein, and I've gotten, not so much because of his science, because I don't understand, I'm really terrible on physics, but he had some really great words of wisdom. If you always do what you always did, you always get what you always got. And there's the kind of corollary to this is, if you do this, keep doing the same thing and expect different results, that's the definition of insanity. So again, we're not doing as well as we need to do. We need to change something. I love this slide. Just because you've always done it that way does not mean it's not incredibly stupid. Whether they're bulls or bulldogs, if you see the commercials on TV. So we take it from the mouth of Hippocrates that the way I was trained is the way it should be, and this is the way I'm going to practice medicine until I die. No, it's time to throw down those tools that we've had for so long and pick up some new things that will really enable us to do a lot better. We have to change the process to change our outcomes. So we can no longer go back to tradition. We need to learn new things. Like this cat. How many people, I know people like this. Don't you? No. I can't do this. This is what CMS tries to do to you in CPC. They said, no, you can't do this. What I saw was this, because people in Oklahoma say, there's people who, do you stay within the box or can you think outside the box? I've never seen the box. So I'm out here, and that's what you have to think. Again, what is play? Think, well, how can I do this differently to really make it work? You have to think that way in whether it's CPC, whether it's Medicare Advantage, regardless, you have to think around you. Don't look at what's in front of you. Look what's around you. There's a lot of capabilities. And there's this couple that are arguing in the car about, well, you have the keys. No, you have the keys. Sometimes you need someone from outside to look at what's going on to say, no, they're right here. And we don't have that because we're stuck in our box in our office, aren't we? And we can't see the problem. And doctors are bad about this. There was an office that I was working with, and they were really frustrated with their office flow. And for 6 months, and I love this doctor. He was voted the CPC Outstanding Doctor for Oklahoma. He's very good. But he was going about this in a bad way. And he and his partners, there were 3 other doctors, could not figure out what they were doing that was making their process so screwed up. I mean, they got glommed up every day. And they were here. They were this couple in this car saying, what are we doing? Well, finally, one of the receptionists came in and said, I know what your problem is. And they said, well, what is it? And they said, well, it's ear washes. Simple. Something simple. Every one of you does ear washes differently. Some of you put the drops in and they make them wait in the office for 30 minutes. Some of them do this, some of them do that. And it screws up the flow of patients every day because it was an elderly practice. And so they did an evidence-based review of washing ears. And they found that it really didn't make a whole lot of difference. It doesn't help to make them sit there for 20 minutes. And it solved the whole problem. But it took someone from outside to saying, no, you're looking at the whole problem wrong. Again, and then they started to play with it, and everything turned out very well in the end. And then there are people like this. And I've seen doctors do this a lot. And it just hurts me to watch doctors using data sometime. Now, cost. And you've heard me say that, in America, we'd have $4 trillion in surplus if we spent as much as the next most expensive country on healthcare. Even in America, there's wide variation. Anybody ever seen the Dartmouth Atlas? The Dartmouth Atlas is very interesting. They'll take a thing like tonsils, TNA, and they'll say, okay, here's two towns 50 miles apart. What is your incidence of TNA? Tonsillectomy, adenoidectomy. And it can vary 50 points. Well, is tonsillar disease so much worse in that other neighborhood? No. It's unnecessary variation in practice. This is not anything but unnecessary variation in practice. It's because tradition, we're in that little box, and that's the way we're going to practice. And we looked at Oklahoma as well. This is kind of more across the country. I had a hard time, and it's hard for patients to get this too, because they're part of the problem. Insurance companies are part of the problem. Physicians are part of the problem. No single raindrop believes it's to blame for the flood. We're all to blame for the flood. We're all part of the problem. And it's only by all of us working together that we're going to solve this. One of the things that I attribute our success to is we really viewed medical home as a point of discipleship. And this is a verse from Timothy, what you've heard from me before many witnesses, entrust to faithful men who will be able to teach others also. Because you're here, but your peers are not. And you're the choir. You need to go out and tell the other people about this. So it's a form of discipleship and evangelism, if you will. When we use the principles of discipleship, we did better. Even when that included prayer. Because there are some doctors, they're so dense, and they just didn't get it until we prayed for them. Now, what causes all this increased healthcare spend? Well, let's bring it down to kind of simplistic things. There are catastrophic cases, and there's nothing you can do about that. If someone gets hit by a car, sorry, they did. We had a situation in Stillwater. They were having a homecoming parade, and this driver came in and hit 50 people, just sent them all to the hospital. There's nothing we could have done about that. I mean, you can't case manage that. So you accept it. There are chronic conditions with expensive therapy. And I'll touch on a couple of those in a minute. The short-term conditions with expensive therapy, the classic condition there is hepatitis C. It's $100,000. I guess it's down to 60 now. Cheap. Until they get it again. There's inpatient care, some of which is avoidable. And that's what we focus on. But some of it's not avoidable. And that you just have to deal with. Again, if a person, whether you say this is avoidable or not, someone has a heart attack or a stroke, they're in the hospital. You can't really avoid that. But a readmission for heart failure, an admission for COPD, a readmission for COPD, a readmission for a wound infection, some of those things can be prevented if you treat them right up front in ambulatory care. There is a lot of savings available in ambulatory care. And then there's these expensive new therapies. Gaucher's disease. Anybody ever had a patient with this? Okay. There's one drug, FDA approved for this condition. It costs $440,000 a year. And over the course of life, it costs $50 an hour for every hour that person's alive. You're stuck. Nothing you can do about it. To me, that's a catastrophic case. Sovaldi. If you treated every infected American who has hepatitis C, it would cost $250 billion, and the entire budget for drugs for Medicare last year was $263. So almost as much as the entire drug budget for Medicare. It's a problem. And then drugs for these, I mean, the multiple sclerosis drugs, they're all $8,000 to $10,000. We finally broke down. There is an advantage in being the chief medical officer for a health plan, because I was getting really frustrated by these MS drugs. In Europe, they're 1/3 the cost they are in the United States. And I don't understand that. I tried to get the drug companies to explain that to me, and no one could. Then I saw an article in JAMA that said, you can do stem cell transplant for MS, and the outcomes, you can induce remission of MS in those patients. And within 2 months after I saw that article, I got a request for a stem cell transplant for MS. And this was in a 40-year-old woman who was disabled. She had to quit work due to her MS. So we sent her to Northwestern, which is where these are happening. A year later, she did the Tulsa Run. It was a 5K, but she didn't do the 15K Tulsa Run. She did the 5K. Back at work. Disabled the year before. Now, normally you see people maybe get better. I mean, they have that kind of fluctuating course with MS. You don't get that much better. It was amazing. The drugs for RA are the same. The inflammatory bowel disease, they're $8,000 to $10,000. There's the new drug for cholesterol, the PCSK9 inhibitors that are $14,000 a year. And we met with a cardiologist to tell us how to use these drugs, and they put criteria. But there's the 2 cardiologists that didn't come are the ones who are ordering the drugs, and they're ordering them on 80-year-old men whose cholesterol is 107. It's just, why? Lupus, hemophilia. We had one gentleman who developed inhibitors to factor, and his factor costs in 1 year were $6 million. His total costs for that year were $10 million. I mean, he made the difference between us being profitable and not. Just one patient. For inpatient care, again, with CPC, one of the things they really have you work on is ambulatory sensitive conditions, COPD, CHF. Again, if those conditions are really well treated on an outpatient basis, and we talked about this, you limit the risk of them being admitted to the hospital. A lot of primary cares in our area were having problem maximizing therapy for CHF. They would start them on 5 milligrams of Vasotec twice a day and leave them at that dose. That's probably not going to help you. You need to increase the dose. That's how you do it. With COPD, we had a lot of trouble with some of our physicians. We had one group that really worked hard on an evidence-based COPD rescue kit. It's a pack of steroids, an antibiotic that you send home with the patients with clear instructions. If these things happen, this is what you do. And we saw a dramatic decrease in hospitalizations for COPD. And then we had this other group of physicians that say, I don't trust my patients that much. Yeah, so your autonomy is more important than your patient's health. It kind of makes me wonder. So, I think we need to trust our patients a little bit more. They need to be educated, yes, but case managers really help with that. The readmissions, especially COPD and CHF, are more likely to readmit than most other diagnoses. And then watch out for that frail elderly, frail elderly syndrome I was talking about. Skilled nursing care, you're more likely to readmit from skilled nursing, so really watch out for those people. The elective procedures, preference-sensitive conditions. Specialists rarely encourage shared decision-making. My wife is a good example of this. My wife knows that I use her as an example, so it's PHI, it's okay. She plays tennis. She's about 7 years younger than me. It wasn't statutory rape. And her knees were hurting, and so she went to the orthopedist. She picked one and went to him. And he said, "You need a knee replacement." And she came home and she told me, she says, "Well, the doctor said I need a knee replacement." And I just went, "No." So I said, "Who did you go to?" She said, "Dr. So-and-so." "No. Go to Dr. So-and-so over here and let me know what he says." Well, he went to the other orthopedist and says, "Well, I think you need some physical therapy and you'll be fine." So she had 4 visits of physical therapy, all of her pain went away, she's fine. And that was 10 years ago. She still has her knees and she's fine. So be careful with this. You know, hysterectomies for dysfunction, abnormal uterine bleeding. Is that really necessary? You know, knee replacements. Viscose supplements, are those used a lot here? Some? Have you looked at the evidence behind those? Yeah. $1,500 a knee. Medicare covers it. And then encouraging palliative care when appropriate. If you haven't read Being Mortal, I strongly encourage it. It should be a must-read for everybody in the medical profession. In Oklahoma, we really pushed the advanced directive. I know that's a big part of CPC Plus now. And if you haven't heard the physician orders for life-sustaining treatment, the PULSE form, are you all familiar with that? Okay, good. Some people really like the robotics for surgery. I don't know if you've looked at the research behind this. There's no studies that show that robotic surgery does any better. However, the complication rate is 30% higher than with non-robotic surgery. And we think a lot of it is because you can't sterilize a robot. We've seen that with even colonoscopy, that in really good places in Seattle, they've had very high superinfection rates on people post-colonoscopy. They've even developed disposable colonoscopes to get away from this problem. So just because it's new and newfangled does not mean it's better. Now, lab. You're welcome. Physical lab. We are really strong believers in the United States Preventive Services Task Force. You know, because they research and say, okay, what does it show that we can do that makes a difference? There's really not that much. And again, we want to provide all the care that helps, but only what helps. And if I don't know if this is going to help or not, why am I wasting my time? It's not like I have a lot of spare time that I can give to patients. I want to provide all the care that I can that will help them, but not stuff that I don't know if it'll help or not. And this is especially bad with panels. We have some physicians, and I use the term loosely, in Oklahoma that are ordering $2,000 panels of selenium and things like that for no reason. And they're doing this a couple times a year. And it just doesn't make any sense. Genetic testing is especially expensive. Some of it is very necessary. My mother had breast cancer at 41, so I'm a big believer in BRCA. I have no problem with that for people who need it. I have big problems with $90,000 of genetic testing on people who may not really need it, which happened with one of our heart transplant patients. There was a law that was voted on this year in Oklahoma that said that anybody who is in a nursing home for longer than 7 days had to have genetic testing. Well, you know where that came from.
Yeah.
That's right, from the genetic testing labs. And there are nursing homes that are really, and I'll use the word strongly, encouraging the physicians to order this testing on all their patients because they get a kickback. Well, that's unethical at best. So, but is it medically necessary? Is that really helping you? I mean, and again, if that helps you, great. And I mean more than just your pocketbook. Yes?
Gene testing on like drug metabolism?
Yes.
Okay.
Yeah. Thank you. Yeah. Just because something can be tested doesn't mean it should be tested. Offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. I mean, we're almost to this point right now. Imaging, CT lung cancer screening got a big, a couple of years ago in the CPC process. They looked a lot at that. And they do have a very good shared decision-making process for that now. Because, yes, U.S. Preventive Task Force recommends it, but if you look at the marginal benefit that you get from that, it's not very much. And people die from this screening. And we think that all screening is helpful. I had a man 2 years ago that died from a screening colonoscopy because he perforated. And he didn't have cancer, so the screening killed him. And I've had people die of CT lung cancer screening who didn't have cancer. When you're looking at the risk and benefit of, or the recommendations for all those, you have to consider that. And the delta between risk and benefit with lung cancer screening is about 5%. So there is some better, but not a whole lot. MRI, I'm sorry to say, primary care does not generally do a good job deciding who needs MRI. In studies at larger centers like Mayo and Hopkins and so forth, they found over 50% of MR studies were not medically necessary. They've even looked at the exam versus the results on MRI, and the results you get from a good physical exam are as sensitive and specific populationally as an MRI. And I've covered a lot of knee surgeries in people who had a normal MRI because the MRI was a false negative. So that's a problem. So think about it. There's a lot of newer things also. It's atraumatic knee pain essentially never needs advanced imaging. Even traumatic knee pain rarely needs imaging. There was a very good study in the American Family Physician Journal, and this was written by a family physician, not by a health plan, that said that health plans should consider not covering arthroscopic meniscectomy because the evidence showed that physical therapy was as effective and less injurious to the patient than arthroscopic knee surgery for a meniscal tear. That was a big act of faith. I'm not going that far, but that was in print in our journal. Headache, back pain. I can't tell you how many people I see got ordered an MRI first visit for back pain. Well, I want to find out what's going on. It's like that person with the arrow through their head. They pulled their back. They played golf for the first time in 6 months, and so these are some things that we can do to save money. I wish it was this easy to fix that. Just fix it on Photoshop. We're just not there yet. Orthopedics hasn't gotten to this point. Could you have your husband work on that? Do the Photoshop thing to fix the orthopedic problems? One of my pet peeves, this is probably Oklahoma, is DME. I have a lot of doctors who order oxygen who don't meet Medicare criteria. Yep, I'm sorry. Question? Okay.
The other side of that argument is that the technology exists. So why not use it? Because it's expensive. Well, why is it so expensive? Why don't we just make it cheaper?
Again, the issue is why do you need to do it anyway?
Do you think it's appropriate? The patient wants to know.
Maybe for the 50% that it does.
I don't believe in therapeutic MRI.
I don't either. But if you're dealing, the flip side of the argument is though that the technology exists, okay? And somebody that has, their kids wants to return to play or whatever, and they want to know.
They can pay for
My
it.
question isn't really whether you should or shouldn't do it, because every case is individual.
Yeah.
I guess my question is, why aren't the tests cheaper? Why is it still $2,400 for a knee MRI?
It's not in a lot of places. We have places in Oklahoma, freestanding MRI centers, so you can get them for $300 to $500, but that's still $300 to $500. And I've never said, you know, as an insurance person, I'm not saying you can't have this, I'm just saying we won't pay for it. So if the patient wants that for their peace of mind or so their kid can return to sports, that's not a medical necessity issue, that's a personal issue. They can pay the $300, $500 and get their MRI. But when you're looking at costs that are this high, why should I be ordering something that's not medically necessary just because I can? I have a hard time with that.
Why do hospitals charge excessive amounts, $2,200, $2,500, when a freestanding imaging center can charge?
Because a freestanding imaging center doesn't have to support an OB center, which routinely loses money, or an emergency room, which routinely loses money. There's more to, and that's why physician hospitals, you know, the specialty hospitals like orthopedic hospitals and so forth, they never have OB, they never have an ER, because those are areas which lose money. You've got to make it up somewhere. Our hospitals don't charge $2,500, they charge $700. It's more than the freestanding, but it's not $2,500. Good questions. Do y'all use Choosing Wisely? Okay. In Choosing Wisely, they don't even recommend using CPM for knee replacement. And again, Medicare covers CPM. That's the only thing for which they'll cover CPM is for a knee replacement. Well, they recommend not covering it. They don't recommend not doing it. My wife, again, my classic example, had a rotator cuff tear. And in Tulsa, every orthopedist, for every rotator cuff tear, will order CPM. Well,
What is CPM?
it's a continuous passive motion machine. It makes you move your,
Oh, a machine?
yeah, it does it for you. It's like those aerobics things that you lay on the table and it kind of moves you. At the same time my wife had hers, our minister of evangelism in our church had his rotator cuff done. He's the same age, had the same injury. He had CPM, my wife didn't. My wife got better more completely and faster than he did, just because she did her exercises. So does it really help? Evidence does not suggest that it does. My personal pet peeve is pediatric wheelchairs. This is a pediatric wheelchair. This is a stroller. There's not a whole lot of difference, except this is $3,000. This is less than $300. Why? Why shouldn't they have it?